Let's talk soft tissue anatomy of the hand, wrist, and elbow. So it seems like a lot of joints that we are combining, but part of that is because all of these muscles are connected and the majority of them are going to come from the elbow and attach down all the way down to the fingers. So one term to really understand when we're going over these joints is intrinsic versus extrinsic. So when we refer to the hand, the muscles that stay within the joint and stay within the body part. So all the muscles that are originally from the hand are attaching to other areas of the hand are referred to as intrinsic muscles and are really small muscles, like the lumbricals and stabilizer muscles. But the majority of the muscles, like our finger extensors and our finger flexors, are coming all the way from the medial and lateral epicondyle or parts of the radius and the ulna and attaching down to the fingers. So that is part of your anatomy class and part of what you should bring into this class. So for this class, we're just going to focus on the muscles and the soft tissue structures that are really involved in hot spots for injuries. And so one thing that you really have to take away from this when we talk about just muscles, I think the biggest takeaway from this module 10 is that the flexors are going to always coordinate with the pronators, and then the extensors are going to go with the supinators, and they're always attaching to the same epicondyle. So for example, let's start with the flexors. So the flexor muscles are going to flex the fingers and flex the wrist. So we're going to bend the wrist and flex the fingers. All of these muscles are going to attach at the medial epicondyle. So go ahead and flex your finger, flex your wrist, and see and feel which side bulges out. You're going to feel a bulge on your medial epicondyle. Now we're going to pronate. So if you remember from anatomy, pronation means pour out, P for pronate, P for pour. So we're going to pour out our cup of soup and we're going to turn palm down. When you go palm down, you will also feel it getting really tight over the medial epicondyle, same place as the flexors. So often they work together, and when you have overuse of one, you're having overuse of the other, or if you have overuse of one, it will affect the other. Now, when you look at the extensors, all of the extensors that are extending the hand, the fingers, and extending the wrist are going to extend to the lateral epicondyle. And then also supination, so we hold a bowl of soup, S for supinate, and S for soup, S for supinate. So holding it up, palm up. If you do that and you go palm up, you're also going to feel that on the lateral elbow as well. So those muscles also work in coordination with each other. So when you think about injury patterns, and that's the big thing that I keep talking about throughout the hand, wrist, and elbow, because this is such a functional thing, like to grab anything or to brush our teeth or brush our hair or open a cabinet or any of these things that are activities of daily living, ADLs, then those are going to get overworked all the time. So it's very common for these to be overused. So if there's certain patterns, like certain muscles that you're using for certain specific activities, you're going to see that pattern. So for example, lateral epicondylitis is the attachment point of the extensors and the supinators. So where that tendon is attaching, that attachment point on the epicondyle, so this big like kind of ball that sticks out from the distal humerus, that area is what gets really inflamed and starts breaking down. So the tendon does, but the attachment point on the bone that it attaches to, the lateral epicondyle, is where the injury is occurring. And that is occurring a lot in tennis players, which is why it's referred to as tennis elbow, because of the constant extension and also supination and the motion of the racket and hitting. Where golfers often get where they're golfing and they have these flexors, and they are often our medial epicondyle. Also, little leaguer's elbow is medial epicondyle. It's slightly different because it's more bone related and it has to do with tissue, the soft malleable bone pulling off. But that's the area of the medial epicondyle is because of that force, that valgus force that we put when we're throwing on immature bones. So it's important to recognize and understand what muscles work with each other and where they're attaching, because those are going to be injury patterns. So if someone's constantly doing extension and supination, they're going to have pain over the lateral epicondyle. If they're doing a lot of flexion and pronation, then they are going to have pain over the medial epicondyle. So muscular wise, that's the biggest takeaway. When we talk about ligamentous stability, two big areas that we need to focus on. One, with the volar plate, with the fingers, underneath the DAP and the PIP, you're going to have a thick piece of cartilage that's reinforcing the joint. And any injury in the upper extremity that's like an acute injury is typically an axial load, either from like falling or getting jammed finger on the end of the finger. And so that usually will hyperextend the finger or jam the finger. And this volar plate really protects that. It's just like the volar plate with turf toe and the great toe. Same thing. If it gets really, really hyperextended, the volar plate can rupture. The other stabilizing parts, you do have some ligaments in the wrist that all wrap around. And then you have an important one, TFCC, that attaches the radius to the ulna. It also attaches the carpal bones and keeps this whole area. It's a very complicated thing, so I've chosen not to talk about that right now at this time. Moving to the elbow, when we look at our medial and lateral instability, its functions. So we have three joints in the elbow. It is a hinge joint like the knee when we talk about where the olecranon meets the humerus, where we have the trochlea meeting with the olecranon and the coronoid process of the ulna. So that is your hinge joint of flexion and extension. So when we talk about that, you do have MCL on the inside, or UCL, and it's our ulnar collateral ligament, and that provides the valgus stability. So this is our main primary stabilizer with valgus stability, and anytime there's axial load, like if you land on it, you're going to have some kind of valgus load. We will get to this in a bit with our pathomechanics, biomechanics, and that important structure there. And then on the lateral side, you have your radial head where you're meeting the capitellum of the humerus, so your radiocapitellar joint. And so then you have an RCL and you have an LCL. So when you look at the picture, you have two ligaments that are very close to each other. Your LCL going more horizontal and your RCL going a little bit more vertical there. You also have an annular ligament that holds the radial head in place as well. So these ligaments are very important in holding that together. The radius of the ulna does have an interosseous membrane, kind of like this syndesmosis we talked about in the ankle, holding these two bones together. They're also reinforced with all of these proximal and distal radiohumeral ligaments as well. So there's a lot of ligaments, but the take-home message here, I think, is understanding the medial versus the lateral stabilization. Understand that we have a hinge joint, then we have a pivot joint in the radial, and then we also just have the radius and the ulna sitting side by side. So it's important to understand what is stabilizing those joints, but we will get more into that and how important that valgus extension overload motion and force impacts the elbow and all the consequences of that in the next pathomechanics and biomechanics section. So if you have any questions about this, please reach out.